Welcome to Chapter 20. Here we will be talking about the assessment of respiratory function. This starts in your text on page 463. When looking at the respiratory system, you want to know its purpose. Of course, when we think about respiratory, what comes to mind first? Ventilation, breathing, our maintenance for life, the thing that we expect to be patent all the time. This is what we should think about when we look at the respiratory system. This is something you will assess every time you check your patient. You want to know both that there is patency and that your respiratory effort is good for each and every patient. When looking at the respiratory system overall, you want to know that there's both an upper and a lower. Your upper, of course, warms and filters your air, and your lower accomplishes that gas exchange. Your lower, we talk about the lungs and the alveolar and the bronchioles, whereas your upper respiratory, we're talking about the nose and the larynx and the pharynx, your tonsils, your adenoids, things of that nature. Here, looking again at those structures of the upper respiratory tract, I do want you to review the information to understand what each structure does and what it is responsible for. So, of course, with your upper respiratory, we have the nose. More importantly, what is your nose used for? That inhales that warm air. You want to know that it has bony structures called turbinates. They increase your mucous membranes. So, you have an understanding of how our sinuses can then act up and how we get congested, what's actually going on in there. Our nasal mucosa that traps all that dust. Here's when we get to discovering what allergies we have. Some are allergic to dust and grass and things of that nature. Some of those nerves in the nose detect odors, of course, and others provide that sneezing action if you have an irritant, such as dust. Looking at your perinasal sinuses, those are your common sites of infection. So, note when people have a sinus infection, these are where it actually occurs. Then you have the pharynx, tonsils, and the adenoids. Those are also some sites for infection. You want to know what each structure does. More importantly, looking at your tonsils, you want to know that these serve as a guard to the body from those invasion of microorganisms. We want to keep all the bad stuff out. So they serve as a guard back there at the back of your throat. And here is a true or false question in regards to the larynx. And here is the answer with the rationale. And then here shows an illustration of your perinasal sinuses. And note that the differences. So when you do have an infection, you can actually have an understanding of why the patient has pain where they actually tell you they have pain, because you can see they may say they have pain right between their eyes, which can be their ethmoid or their sphenoid, or they may have pressure right where their cheeks are. That would be your maxillary, or on the sides. Or they could say, oh, I have, pain right where my eyes are, or right where you would think your temples are. That would be your frontal perinasal sinuses. So now you should have an understanding of if the patient presents with a sinus infection of some sort, where they may tell you they have some type of pain or discomfort. Here it shows an illustration of the cross-section of the nasal cavity, again pointing out those turbinates there. You have superior, inferior, and your middle. Then it goes over your hard and soft palates. Now, when looking at the lower respiratory system, this is the more interesting part. This talks about your lungs, your two lungs. You have a right and a left. So your left has an upper and a lower, whereas your right has three. It has an upper, middle, and a lower. You have the pleura mediastinum, your bronchi, your bronchioles, and your alveoli. Again, review any of this A and P that you need to refamiliarize yourself with. And it starts in your text on 465. Of course, importantly, you want to know that there's two lobes. You want to know that the right has more. You want to know that the left has an upper and a lower. As far as the other structures, when we talk about the lower respiratory system, I want to point out just a couple of things. One of which being your bronchioles. You want to know that those contain your submucosal glands, and they produce mucus, which covers that inside lining of the airways. That helps our airway stay moist. This is why some people need humidity in their oxygen, because that lining is decreasing. And what is the first population we think of when we think of a decrease? Our elderly population. Also, our alveoli. Note that our lungs are made up of about 300 million. And these are pointed out in your book, I believe in figure 20-4 on 466. You also want to note that there are three types of alveoli. Your type 1 serves as the barrier between the air and the alveolar surface, whereas type 2 produces type 1 and surfactant. Surfactant is the important player here when we talk about alveolar. And you may have already discussed this in maternity. Your surfactant is what we need for our lungs to go ahead and expand. We need that surfactant. It helps our lungs mature. So, hence, when you have a premature infant, they may give the mother surfactant to help get those lungs strong and working so that they don't collapse. And then, of course, our third type of alveolar cells are your phagocytic cells. They ingest that foreign matter. So in each part of the body, we need something or some cell that will go ahead and work as a foreign defense mechanism that kicks out any foreign matter. So for that, it's our type 3 alveolar cells. And they provide that defense mechanism for our lungs. Here is another illustration, which is pointed out in your text on 465 as well, which goes over those lower respiratory system. It points out your alveoli, your lungs, both the right and the left, and some of your other other structures. Again, we look at the alveoli. Of course, this is where your gas exchange takes place, diffusion of your O2 and your CO2. You want to know that diffusion works from an area of higher concentration to lower concentration. So you want to know what's actually going on when we're looking at that air exchange. And here's an illustration of the lungs, an interior view. Now looking at ventilation and breathing. This is what we need to sustain life. We need breath. So our thoracic cavity is an airtight chamber. Our diaphragm is on the floor of this chamber. So note when you have something in the lower abdominal region that is causing a disruption, it may then push on your diaphragm, which then makes it hard to breathe. Of course, your inspiration, taking that deep breath in, that contracts that diaphragm. Whereas our expiration, we exhale that air, that's relaxation of the diaphragm. So note again, if you have any abnormal structures in the lower abdominal cavity or something brewing down there, that may indeed affect our respiratory system because of where our diaphragm is. So, of course, looking at respirations, one respiration equals inspiration, 1/3 of the respiratory cycle, and expiration, which is 2/3 of that respiratory cycle. Here we look at perfusion and oxygen transport. You want to have an understanding of how oxygen and carbon dioxide both enter and leave the body. Also, talking about perfusion and looking at carbon dioxide transport, again, knowing how both O2 and CO2 are entering and leaving the body is an important task. I also want you guys to look at the ventilation and perfusion balance and imbalance, which is found in your text on 468. Here we go over gas exchange and respiratory function. I don't want you guys to try to memorize this chart, but it does give you a better illustration of what is explained in the text as far as your O2 and your CO2 and how they enter and leave the body. There's also a good chart in your text on 469, chart 20-2, which goes over your ventilation perfusion ratios. More in-depthly, it goes to explain that VQ ratio for adequate gas exchange and how it is balanced. Of course, if it is imbalanced, it causes shunting of the blood, which can then result in that hypoxia. So you can see how one thing can lead to the other. Of course, that is why we need that supplemental oxygen at the bedside so that that can prevent or eliminate hypoxia from occurring. And here is the answer with the rationale. Here we look at assessment of those breath sounds. You want to know the difference between a normal breath sound and those that are abnormal, also known as adventitious. So if you have an adventitious breath sound, you want to understand what you need to do about it or what could be causing that adventitious breath sound. You also want to assess your patient for dyspnea or difficulty breathing. If your patient's having difficulty breathing, ask them on a scale of 1 to 10, how difficult is it for them to breathe? You are assessing this just as you are assessing your pain on that scale of 1 to 10. You also want to look at the patient and assess them for tachypnea or hypoxemia. Orthopnea is also noted, which is that inability to breathe easily, except for when the patient is sitting upright. So these are all things that you want to look at when you're assessing your patient. And note, if you need a refresher on how these adventitious breath sounds actually sound, you can find them on a YouTube channel, and they are very, very distinctive. There's thousands of videos and tutorials that will give you the different breath sounds and how they will sound to the ear with a stethoscope. You also want to see if the patient has a cough reflex and know that it results from that irritation or inflammation. You also want to ask about sputum. If the patient is producing sputum and if you need a sputum specimen, you want to make sure that you get that sputum specimen first thing in the morning. If the patient has produced a specimen and it has been sitting for like 4 hours, then you need to discard that one. And here's a true or false statement in regard to adventitious breath sounds. And here's the answer with the rationale. And now we'll look a little bit at lung capacity. I won't go too in depth with these, but I do want you to understand them. I will point out a few things that I do want you to know about each one. When looking at inspiratory force, you want to look at and evaluate that inspiratory effort in one breath. Is it hard for the patient to breathe? Do they have problems? Do they complain of dyspnea, which is that difficulty breathing? So you want to note that a manometer is usually a device that's seen on a ventilation or your endotracheal tube. So your mechanical ventilation is something you will see a manometer on. And again, you will not have to deal with this. That would not be in your scope of practice, but that does show and measure your inspiratory effort. You want to know that the normal effort or rate is 100 centimeters of water. Anything less than 25 usually requires that mechanical ventilation. So Next time you're in your hospital settings, look and see if you have a patient that is ventilated, if you can determine their inspiratory effort on the manometer with them on mechanical ventilation. Here, looking at arterial blood gases again, this will not be in your scope of practice to actually draw them, or it may be if you are certified. Your respiratory therapist usually comes and draws your arterial blood gases along with interpreting the results, and they will post them for you. Or they may have someone specially trained from the lab. So, of course, it measures your arterial oxygen. It is obtained from an artery. So, note that you are usually not obtaining blood from the arteries, you are obtaining it from the veins. So, usually, your respiratory therapist or someone specially trained will handle that for you. It also assesses your acid base balances. So, it will tell you your pH of the blood, it will tell you, your O2 and things of that nature. When looking at the pulse ox, again, we will talk about this. When we talk about ventilation, we think about our pulse ox. That should be a part of your vital sign ritual when you're taking vital signs to obtain a pulse ox for your patient. Normal levels between 95 and 100. Now, there are some considerations. If your patient has on fake nails, if your patient has on dark fingernail polish, if your patient's fingers are cold, if they have peripheral neuropathies, those are all things to consider that you may not pick up a good reading when it comes to looking at that particular strip, or that, reading for that O2 sat. So do assess the patient. It will not likely be the O2 probe. It's usually something that's going on with the patient. So make sure it is a part of your vital signs. Although it is not as reliable as we would like it to be, the most reliable would be your arterial blood gas, but the physicians or healthcare providers will take that as a viable reading when you do obtain that. Here is just an illustration of a typical pulse ox. They have the portable ones. B is a figure that is not so portable. It usually, stays at the nurse's station or in the patient's room. The portable ones, as seen in A, we can take those with us on the go, and usually those are the ones that the respiratory therapists have with them. Again, when looking at a health history and talking to our patient, we want to look at the patient's problems and any associated symptoms that they may have in regards to their respiratory area, as well as exploring any medical conditions, any injuries, hospitalizations. Of course, we want to ask about allergies, and we want to assess for those risk factors. You want to look in your text on page 474 at risk factors for respiratory disease. That is chart 20-6. Of course, smoking is at the top of the list. That's the single most important contributor to lung disease. And the second one is exposure to secondhand smoke. Also, you want to look at genetics in nursing practice, which is found in chart 20-7, which goes over respiratory disorders. Now, various conditions that affect gas exchange and respiratory function are influenced by genetics. Those that include asthma, your COPD or chronic obstructive pulmonary disease, and cystic fibrosis. Those are three of the important ones that you will see quite often and that can affect other patients when it comes to their risk factors in lung disease. getting that physical assessment, you want to look at the patient's general appearance, look at clubbing of the fingers. We will go over that in class, and I will actually show you how you can assess yourself to see if you have clubbing of the fingers, looking for any cyanosis, checking that skin color. For your African Americans or those with darker skin, you can look at the mucous membranes, you can look at the eyes, you can look at the palms of the hands. Those are areas that you can look at. You can look at the fingernail beds. Also, you want to check, the upper and lower respiratory structures. So you want to check the neck, you want to check the lymph nodes, you want to check the sinuses and see, if they're having any pain within the sinus area, if they have patent nares, if they can breathe out of each nostril, things of that nature. You want to listen to the lungs. So you want to do a thorough assessment. When looking at diagnostic testing, one of the major ones I want you to pay attention to is pulmonary function testing. We talked a little bit about pulse oximetry, but I want you to look at pulmonary function testing. That's found in your text on 484. Of course, they are performed to assess the respiratory function and determine the extent of dysfunction. Of course, in response to therapy and as a screening tool in potentially hazardous industries such as your coal mining and things of that nature. They include measurements of lung volumes, your ventilatory function, and mechanics of breathing, diffusion, and gas exchange. So it tells us how your lungs are working, basically. Again, we reviewed your ABGs, and they're aiding in the diagnosis of some respiratory disorder or dysfunction, your pulse oximetry, and what we expect from that. Sputum specimens, I talked a little bit about that. You want to look at that in your sputum studies. And also looking at imaging studies, the one I want you to pay closer attention to is the MRI. Of course, your MRI is used to confirm usually your chest x-ray. So if they see something on the chest x-ray, they will usually order an MRI with or without contrast or both to see, is it really what they think it is. So, for example, if your patient has bronchogenic carcinoma, which is cancer of the bronchioles, and they suspect that on the chest x-ray, they will order an MRI, which would then tell them or confirm for them if that is the case and if it has invaded the chest wall. So those are things that your MRI would do for you. You also want to look at the pulmonary angiography and the nursing interventions. What can be done for that? Again, here are some more diagnostic testing that can help or assist your healthcare providers in giving diagnosis and treatment for your patients with respiratory disorders and diseases. The one I want to look at is a bronchoscopy or a thoracoscopy. I want you to look at the nursing interventions. I want you guys to understand what your role is as the nurse when it comes to these diagnostic studies and any testing that needs to be done, and how you as the healthcare provider can assist your patient. So if your patient is going for, let's say, a thoracostomy or a thoracoscopy, You want them to be NPO, which is nothing by mouth. You want them to do this before the procedure. Usually it's several hours before the procedure that they cannot eat or drink. If it is in the afternoon, of course, we're not going to have our patients NPO after midnight and their procedure is not till the afternoon. They may let them eat or drink until like 8 a.m. So usually it's several hours before that we do want them to be NPO. So make sure you look and see what the procedure is or what diagnostic test they're getting and any special treatment or interventions you may need to employ before that occurs. And here's just an illustration of a bronchoscopy and a rigid bronchoscopy. And note the difference of how the patient is positioned. And then here is an illustration of a endoscopic thoracoscopy. And these are also found in your text. So do look at those and see what is actually going on and what they actually do with the procedures and what your role is as the nurse. And once that's done, that will complete us for chapter 20, which goes over the assessment of respiratory function.